Hey everybody, welcome back to Fertility Factor Fiction, the best infertility show on the web, if we do say so ourselves. We are happy to have you guys back. We have a great topic tonight. It's not actually a study. We're just going to review everything we know about marijuana to date and fertility. So I hope you guys are watching. We hope that you've had a good week, and hopefully more and more of you are getting vaccinated so we can end this horrible plague that has been ruining all of our lives for over a year now. So I hope you guys are well. Welcome back. As usual, we're going to let everybody have a chance to jump on board and make sure that you can join us. And we're going to grab some tea. I've got my jasmine tea back, and I've got Tarek back. So thank you to all of you for your well wishes last week. Tarek was unavailable due to some personal health concerns, but he is now back by my side, so he's manning the computer.
COVID, not COVID.
It was not COVID, he wants me to say. So he's back and he's in command again, so we should have a smooth and good running show. Hopefully we're up on Instagram too. Did you check? So hopefully everybody can hear us. There shouldn't be any sound problems or visual problems. Everything should be good to go, and we're going to get started shortly. So I actually have kind of a PowerPoint presentation for you guys tonight, and we'll go through the individual little topics and review everything. And then if you guys have questions, I'm more than happy to take your questions. So I think we can probably get started if we've got enough of a build up there. I think we're still waiting for a few more folks to join on and go from there. Nothing really exciting in the infertility world lately. No major breakthroughs, no major announcements. In fact, one of the reasons I ended up choosing this topic tonight was because there's actually very little even coming out research-wise to share with everybody that's momentous enough or significant enough for us to present to you guys. And we do get a lot of views on our YouTube channel now for any video we put out. So these informational type presentations I figured were a good deal. I also think it's a great opportunity to point out the fact that the recent post we put out on Instagram on how miscarriage is allowed time off, paid leave in New Zealand got 17,500 people to view it, and yet Instagram didn't promote it, and we actually had 2 less followers as a result. So that necessitated my putting out my other post about how I have no idea how Instagram math works, and it's been an interesting social media uphill climb with Instagram. But YouTube is easy. We get about 20 new followers a day, and the videos do really, really well. So thank you for all of those of you who have watched and spread the word and shared and liked and commented. So we'll definitely continue building up that element of our practice. Okay, so we're going to start with our slideshow. So the question is marijuana safe when you're trying to conceive? So that should be the first slide. Is it up? Yep. Okay, perfect. So this is an interesting topic. We have had all sorts of people come in who believe it's safe. We've had people who refuse to go off. We've had men, we've had women. Typically it's the guys that don't want to stop, but we have had women that are using. I had an egg donor not too long ago who was using it several times a day. And when I spoke to her about it, I said, listen, you cannot use marijuana during your fertility cycle, so it's imperative that you stop. And she said, well, let me think about it, and then was kind enough at least to call me back a week or so later and very honestly tell me that she couldn't stop. So it is like a major part of our culture now, in particular in Canada where it's now legal. It's actually fairly difficult to get people to not be on marijuana. And that can include surrogates or egg donors or the patients themselves. So I thought this is a hot button topic. Let's review it and see what we can help bring to people's attention. So we're going to go to the first slide. So Marijuana use is way more common than anyone would anticipate. So obviously it's becoming more and more common in countries where it's legalized. It's obviously very common. And most people don't understand the harmful or the detrimental side effects of using marijuana. So the question is, what is the epidemiology of this with fertility? So 9.8% of people will use marijuana while they're trying to conceive, up to 13% of patients that were presenting to a fertility clinic. So that's a fair number. I mean, that's about 1 in 7, 1 in 8. So there's a lot of people that are using. And these are patients that are actually trying to get pregnant and having difficulty. So it's the representation of the same folks out there like you who are watching this show. Interestingly, in one study that they looked at, they said 72% would have agreed to stop if they were asked to, and only 9.4% were actually asked to. So as physicians, we are not doing a good enough job in telling patients to stop or to quit or to at least hold off. Now, all of you who have watched our show or have come to see me know that I am vehemently opposed to any smoking, any drug use, and I try to eliminate or at least absolutely minimize alcohol intake. But obviously other physicians are not doing that. They're just letting patients continue. And why do I do this? Well, I'm going to show you that the data is strongly in favor of not using marijuana. And as a result of that, we want the very best for you guys. And that's why we tell you to stop. So you'll see through the data here that it's important. More importantly as well is that many people are continuing marijuana use even through the pregnancy, and that's over 5%. And there are different reasons like nausea and vomiting, and some women are using it to sleep better. And in many cases, it's just addiction. And although people don't believe you can be addicted to marijuana, there are a lot of people that are actually addicted to marijuana. It is an addictive substance. So the prevalence of this is very high. The incidence of the use of this is quite high. And as more states and more countries make it legal, you're going to see a higher use and a growing use over time. So this is really important. So we're going to go to the next slide. So these are kind of just the objectives here, and it's to talk about the safety of this. So is it safe? So we're going to look at sperm parameters. We're going to look at female parameters. We're going to look at the embryo factors, the fetal factors, and then at the end, we're going to briefly talk about sexual function. Oops. And I'm going to sneeze. Oh, excuse me. Okay, so sperm parameters. So I found this great pic in the background that looks like marijuana sperm. So I love that image. Well, thank you, Shutterstock. So there are meta-analyses of how it impacts sperm parameters. So a meta-analysis, remember, is when they take a bunch of different studies and they pile them into one to get one bigger study. So the studies show in 6 out of 7 that there was a reduced sperm count by almost a third, significant reduction in sperm motility, anywhere from 28 to 56%. Now they do specify that if your sperm motility is really good, it's only a 28% reduction, which is still very significant. If your sperm motility is not very good, it's an even greater reduction in motility. So that's really critical. They looked at morphology, which is the shape of the sperm. Are they normal or abnormal? And remember, the abnormal ones are not thought to work. And there is a 94% increase in the number of men that have less than 4%, only 4% of their sperm having normal morphology, which is just an absolutely massive increase, okay? They then looked at viability, so that's the number of sperm that are actually alive, and they saw a dose-dependent reduction. So the more marijuana you use, the less of your sperm that are going to survive. And then they looked at activation and fertilization, and that's the ability of the sperm to actually activate and cause what's called an acrosomal reaction in the egg when it binds, as well as the chance that it will actually fertilize. And again, they showed significant reductions. So from a sperm parameter standpoint, when we're looking at the number of sperm, we're looking at the motility, we're looking at the morphology, and then the viability, there is no question that it is significantly hampering the function and the quality of the sperm. So we're going to move to the next slide. So the next part of this is, what if you're not just looking at those parameters? What about sperm DNA fragmentation? So we've talked about sperm DNA fragmentation on the show. There are people more and more now that are adopting sperm DNA fragmentation into their practice because it does look like it has a significant impact on some outcomes. So for IUI, if your sperm DNA fragmentation is high, there are some studies that show no success. For IVF, you're probably getting decreased fertilization, decreased blastocyst production, and we know for a fact that you are getting a higher rate of miscarriage. And that miscarriage rate is much, much higher, almost close to 12 times higher than normal in one study we reviewed here on the show early last year sometime. So with sperm DNA fragmentation, the risk is that you're going to compromise your fertility, you're going to increase your miscarriage risk. So it is a 250% increase in the risk of miscarriage, even if it's only the male using the marijuana. And it's a 60% increase in chromosomal abnormalities in the sperm. 60% increase in sperm DNA fragmentation as well. So a huge, huge alteration in the quality of the sperm, a huge alteration in the numbers. You are seeing massive increases in abnormalities. So remember that inside your sperm there are chromosomes, and this is showing that 60% of the sperm will show an increase in the sperms having chromosomal abnormalities. You'll have a 60% increase in DNA fragmentation and 250% increase in the miscarriage risk, even if you are successful in helping your partner conceive. So this is critical and clearly very, very damaging to the sperm quality. So incontrovertible, this stuff is like hardcore nailed down science. They know that these are problems. Okay, so we're going to go to the next slide. So looking at the female impact, it's a little bit harder because there actually is not a lot of data looking at this. So hard to know because it's hard in a woman to figure out if there's an impact on egg quality and sperm quality, or on fertilization and so on, because it's hard to kind of do a randomized controlled trial. You can't really intentionally expose people to marijuana. And it's hard to follow because you don't know about all of the other confounding factors in a female, which you can't necessarily control for as easily. What we do know, it extends ovulation by anywhere from 1.7 to 3.5 days. And oftentimes the longer it takes for you to develop your egg, the lower the quality of the egg. It can increase anovulatory cycles. So in one study alone, 43% of the women that were not having periods were marijuana users, even though they actually only represented 15% of the total population of women they were looking at. So huge increase in the chance that you won't ovulate. There does not appear to be a significant difference in implantation, clinical pregnancy rate, or live birth, but if you go to the next slide, you'll see that it again doubles the risk of miscarriage. And this is from a study looking specifically at women, analyzing what their outcomes were with IVF. And they showed that if the woman was using IVF, the risk of miscarriage was double the background rate. So obviously you're going through all that trouble, all the angst, all the emotion, and now you've got double the background risk of a miscarriage, especially after you've spent probably a fortune paying for your IVF cycle. There's also significant alterations in the endometrium and placental development. So the development of the lining of the uterus and the development of the placenta are significantly altered by marijuana and the THC. How much so? 1/3 of the THC that's in a woman's blood will actually cross the placenta. So you know that your baby is actually being exposed to the marijuana on an ongoing basis at a relatively high concentration. And in case you weren't aware of this, the cannabinoid system, which includes the receptors for THC, is present all over the human body, including neurodevelopmental tissues, reproductive tissues. And the authors of these studies are saying it can be a significant enough alteration in the fetus that it can actually have lasting impact that your fetus could actually then be passing on to its offspring. And therefore you could be affecting your fetus is then affected for life and passing that down through the generations. So this has very, very tangible, significant negative impact on reproductive health. So final slide is to see fetal factors. So we have this confused little baby. And why do we have a confused little baby? Because it can actually impact fetal development. So babies that have been exposed to marijuana in utero have decreased sleep. They have fundamental anatomical changes in the areas of the brain that regulate emotion. They're at a higher risk for having intrauterine growth restriction, heart defects, and they have reduced viral immunity, something that up until recently we probably wouldn't have been jumping up and down about, but that we now have to be very cautious of because we're in a worldwide global pandemic, obviously caused by a virus. So these babies have weaker immune systems, specifically against viruses. They can be smaller. Remember, being smaller, you might think, oh, easier delivery. No, the problem with being smaller is when these children grow up to be adults, they're at a higher risk of high blood pressure, heart disease, diabetes, many other health conditions. So being smaller is not a minor thing. They also have lower IQ and reduced verbal and abstract reasoning scores. And as though that wasn't enough, as they get older, the risk of having attention deficit hyperactivity disorder is also elevated and increased. The last thing that we looked at was sexual function. So if you flip to the next slide, you'll see that this guy is holding the ubiquitous little blue pill. And the reality is that it increases the rate of erectile dysfunction by double. So you are doubling the chances that you will have sexual dysfunction, making it obviously that much harder for you to get pregnant. Now, interestingly, in women, if you were using low doses, they said it improved your sexual function. But at higher doses, again, it slowed down or retarded the sexual function in women when they were smoking more frequently. And so on balance, when you look at this in terms of the benefits of having an improved sexual function versus all of the risks with miscarriage, alteration of the baby's anatomy, the brain function, outcomes long-term, ADHD, miscarriage risks, and so on, there is no question that that small increase for women that are suffering from sexual dysfunction is not even close to being worth it for the risk that you're taking in staying on marijuana. So this isn't quite a factor of fiction. I don't get to kind of slam the gavel as I normally do and say, is it a factor of fiction? But the reality is there is no element of marijuana that is safe when you are trying to conceive or when you are pregnant. Now, there are some studies that have shown in men that there are some improvements to sperm quality. That was one of the studies. And there's actually even one study that showed an increase in live birth. However, it's still not counteracted by all of these other elements, including the increased risk of miscarriage, all of the adverse sperm parameter effects, and all of the other health effects that it has. Years ago, there was an excellent article released as a review article in the New England Journal of Medicine, which reviewed the actual adverse side effects of marijuana use. And the one that is the most convincing of all is a study of CT scans of brain volume in users versus non-users. So when they compared men and women over the age of 50 and did CT scans of their brains to see if there were any differences comparing the never used to the previously used marijuana patients, they demonstrated that the brain volume was statistically significantly smaller in patients that actually had that had used marijuana compared to the patients that had never used marijuana. So we've known for a long time it can be damaging to neurological tissues. And in many cases, it can alter or even destroy your neurological tissues. And therefore, if it is shrinking your brain volume, that cannot be a good thing long term. Those people have a higher rate of blackouts, memory loss, difficulty concentrating, short-term and long-term memory problems, focus deficits, all of these things. So In the same way that it gives you that ADHD when you're younger, this can have much longer lasting impacts than just that, well into your adulthood and into your senior years. So overall, is it safe to use marijuana when you're trying to conceive? It is absolutely not safe to use marijuana when you're trying to conceive. So thank you for watching that part of our show. We love doing this for you guys. Make sure you like, comment, and share, and subscribe to our YouTube channel where all our videos are available for you. It's www.youtube.com/drvictory for Dr. Victory. And thank you to Tarek for running our show for us and getting this all up there in a format that hopefully people on Instagram could see as well. So we are going to take questions now. And I think Tarek has a whole bunch of questions for us, I'm sure.
So one related to today's subject.
Topic? Yeah,
yep,
sure.
Today's topic
yep.
is, where did it go? It was about the study had to do with, keep scrolling up, CBDs.
Yeah.
And is there anything about that?
Yeah. So no one has broken down in the infertility literature whether CBD alone without the THC is safe or not. We don't know the answer to that yet. However, I don't feel comfortable at all telling anyone that it is safe to use any component of it until we know. So I would refrain from doing that, unless you've got some sort of chronic condition that necessitates you are on cannabis to the exclusion of every other type of agent, or at least on CBD to the exclusion of every other available agent out there. So if you can't use anything else, that's a different story. But if there is an alternative for you to use, you should be on an alternative and not on CBD.
What are the top vitamin supplements you recommend for male sperm count and motility? Thanks.
So we don't necessarily recommend or endorse anything. In fact, I don't think I'm allowed to, according to the College of Physicians and Surgeons of Ontario. But we do use a lot of Fertil and Fertile Pro. So I know those are terrible names because they're kind of the opposite of one another and makes it confusing. But Fertil is from an Austrian company. It's imported into Canada. It's an excellent product with research that backs the improvement both in sperm parameters and a reduction in sperm DNA fragmentation. Fertile Pro is from a Canadian company. It's a little less expensive. It's a great product. We've had lots of success with it and seen great improvements in the sperm quality. You do have to take multiple different bottles to get kind of the same impact you do from the Fertil, but there is a cost savings there. And if you're Canadian, you're supporting Canada. We mix and match. Typically, if the sperm's really poor quality and I need kind of that extra push, we'll switch to the Fertil. And if it's sort of just kind of correcting some stuff or just trying to make a little bit of an improvement, we'll go with the Fertile Pro.
What do you like to see the heartbeat at 6 weeks and 4 days?
So a heartbeat at 6 weeks and 4 days should be somewhere from about 110 to 160. Occasionally you'll see one that's slower. It is a little bit of a warning sign for a potential miscarriage, but not always. Sometimes you come back the next week and they look perfectly fine. If it is slower than 110, we would recommend a repeat check in a couple of days or a week at most, just to verify that everything's going well. Keep in mind there's nothing you can do, so it's not something to be nervous about, but it is something to address and to follow up on for sure.
Would you recommend Lupron prior to embryo transfer if someone recently had it removed via laparoscopy, removed 1.5 months ago? Thanks.
So if you had I'm assuming you mean endometriosis. So if you had your endo removed with laparoscopy, should you be on Lupron prior to an FET? So the answer to that is there is no study that has looked at surgery versus Lupron or surgery then Lupron versus nothing or anything like that. All we know is there is a study that we've reviewed on the show that shows that if you take Lupron and letrozole for 3 months prior to an embryo transfer when you have endo, that it will improve your success rate. So I do tell my patients who have endo that even if we've treated it surgically, they'll do better on the Lupron and letrozole. I don't know that for a scientific fact, but it makes total rational sense, and here's the reason why. no matter how good a surgeon you are, you're never going to get all of the endo because you can't see it all. Endo can be microscopic where it can't be seen visually. And if you don't take all of the endo out, you still have the negative effect from it. Maybe less, but it's still there. So practically speaking, it just makes good theoretical, practical sense to treat you like you still have endo, and that's Lupron and Letrozole for 3 to 6 months before you do your embryo transfer. So great question, and thank you for asking that. Fantastic, actually.
In almost 95% of IVF stories through friends, social media, and blogs are girls. Is there a scientific reason behind this? Are boys uncommon in IVF?
Well, I think boys are uncommon on social media. I'm one of very few male fertility specialists, and I think I'm probably one of the bigger male fertility specialists on social media. So there are not a lot of us doing the social media thing. I think I read just the other day in frustration with Instagram that somewhere around 35% of Instagram viewers are women 18 to 24 years of age. The rest are predominantly still women at other age groups. So it's a much smaller proportion of people that are watching Instagram that are men, or for that matter, any kind of social media thing. So IVF, at least from what we see in terms of stories and blogs and so on, it's women that are on there doing the research, that are doing the chats, that are on the social media, and going back and forth. So there are men out there, but it's a lot fewer. And I just think that they aren't on social media as much as women are. Is there a biological reason for that? I don't know, but it's definitely a fact for sure.
Can the presence of white blood cells in semen impact the success of IVF? We are getting ready for our IVF after several failed IUIs and have a history of WBC in the semen that was treated with antibiotics. Should we do a semen analysis prior to starting IVF to ensure there are no white blood cells?
Yeah, so probably not in IVF unless the white blood cell is a sign of oxidation or inflammation. Certainly, if you have an active infection, that should be treated. There's no question. But in the absence of an active infection, you should be okay because remember in IVF, if they're doing ICSI, they're going to cherry pick each individual sperm. So the white blood cell is not even in the mix when you're putting the sperm in. So there should be less of an effect. But if it's a marker of inflammation, that's a different story. And if you're persistently elevated, you probably need to look at why you're persistently elevated. Are your vitamins low? Are you smoking? Are you drinking? Are you using marijuana? Is there chronic irritation or inflammation from an infection? Do you have prostatitis? So on and so forth. So it is worth looking at. And I'm a big believer in optimizing sperm prior to doing IVF. We, in fact, tell patients frequently to delay their IVF cycle until they're ready to get successful with doing their sperm, or making their sperm improve. Because just jumping into an IVF cycle with poor quality sperm is not a recipe for success. It's a recipe for a very upset patient who's not going to get the outcomes they were expecting.
So follow up to the boy IVF question.
Yeah.
She says, sorry, my question was, why are more girls' babies being born via IVF than boy babies?
Oh. Because male sperm is weaker than female sperm. And actually, it's not just IVF, it's worldwide. There are more women being born than men. So Y-bearing sperm are weaker than X-bearing sperm. So for women to men, the world ratio is slowly tilting towards more women. Many of you may be cheering, thinking that's a good thing, but what that means is guys get to pick more because there will be less men, which means they will be kind of the limited commodity, and women will be more prevalent. So it's not necessarily a good thing. It's always good to have balance.
What is the usual timeline between the Lupron shot and beginning to monitor for embryo transfer?
Well, it depends on what the purpose of the Lupron shot is. So if you're doing Lupron for endo, 3 to 6 months. If you're doing Lupron just for suppression of your LH surge, you take it on day 21 of your previous cycle, and usually within about 3 weeks, you should be heading towards your embryo transfer, plus or minus, several days, but around that time would be normal. Yeah.
This month was supposed to be my retrieval month and was canceled due to a cyst. How does an estrogen producing cyst develop, and how do you prevent this from happening in the future? I've never had an issue of cysts in the past and was devastated when my cycle was canceled.
Well, I'm sorry you were devastated. On an ongoing monthly basis, there are frequently women who have to have their IVF cycle canceled because of cysts. In many instances, we try to prevent that by using the birth control pill, but you can't do it in someone whose ovaries are weak or when age is a factor, because they just don't respond properly after they've been on the pill. So if you've been on the pill and your hormones are very suppressed, then it can prevent you from developing a cyst. If you have not been on it, it's very much luck of the draw. The question's a great one. What causes the cyst? Nobody knows. Absolutely nobody knows. We just don't know what causes them. It's a failure of some part of the mechanism which allows the egg or the corpus luteum to resorb. And then, of course, it depends on what kind of cyst we're talking about as well. So there are a variety of reasons for why it can happen. We never really know what the appropriate or biological plausible answer is for that question. All we know is that it's very common. It can be devastating, but don't be too devastated, because a brief delay will not negatively impact your cycle. Even in women who have weak ovaries, there's a good study, it was done last year, which showed that you can wait up to 6 months and you will still get the exact same live birth outcomes. So have some faith, hang in there. Had you started on your journey and done your IVF cycle with that giant cyst there, it almost undoubtedly would have interfered. So whoever canceled you did the right thing.
Okay. Dr. V.
That's me.
I know you answer this much, and I'm sorry for having to ask.
Okay.
I lost my paper of vitamins you recommended an endometriosis patient to take. Do you have that info somewhere?
Endometriosis patient?
Uh-huh.
Yeah. So the supplements that work for endo are NAC, so that's N-acetylcysteine. It's coenzyme Q10, and it's turmeric or curcumin. The one our pharmacy carries is called Theracumin, and it's 60 milligrams once a day. So it's NAC, curcumin, and coenzyme Q10. All of those have shown some benefit in improving the natural ability of endo to help. And actually, we have a YouTube video on the natural supplements that work for endometriosis. So if you scroll through our video series, you'll be able to find that. One of these days, Tarek and I will get around to reorganizing all of that stuff, but you'll be able to find it there.
Hi, Dr. Victory. Thank you for doing these videos. They are so educational.
My pleasure.
I'm just wondering, if menstrual periods can be off, the cycle following a medicated IUI with injectables, is it common for a menstrual period to be longer and spotting throughout the cycle?
So there's certainly alterations in your menstrual cycle after we've manipulated your hormones. Spotting wouldn't be that common unless something had gone amok. So you shouldn't be spotting any more than you normally do unless you over thickened your lining on medication or hormones or whatnot. Otherwise, no, you shouldn't be getting spotting, but you may get some alteration in the timing of your cycle, because depending on how long it took you to make an egg or multiple eggs, and whether or not you triggered naturally or triggered because we gave you a trigger shot, were you on Cetrotide or Lupron or anything like that, all of these things can alter what your timing will be with your cycle.
Are growing pelvic pains normal at 8 weeks without any spotting?
Okay, so this is my cover myself statement, right? So anytime you have pain in the early stages of pregnancy, especially the first trimester, even early into the second trimester, you must be checked out, because we always have to rule out an ectopic or a large cyst or a torsion or something like that. So if you have pain, it's not really normal, you should get checked out. If it's just mild and nothing's happening and it's not getting worse, it's not likely to be anything, but that doesn't obviate the need to get examined and checked out. So if you have pain, you must be seen, you must be evaluated, you need an ultrasound, you need your betas followed, and so on. Is some cramping normal? Absolutely, as the uterus stretches and grows, especially if you have a smaller uterus or you have endo, or it's your first time. Yeah, there's always some aches and pains. So can it be normal? It can absolutely be normal. In all likelihood it is, but you cannot take a risk. If you think you have pain, you must be evaluated to rule out an ectopic pregnancy. Super, super important.
Hi, I'm wondering how Lupron can have such different reactions from 1 month to the next. In December, I was preparing for an egg retrieval and the Lupron worked perfectly with barely any side effects. Now this month I am preparing for an embryo transfer and have been on the same dose of Lupron for the past 3 weeks and have had every side effect affecting including a full-on period. My estrogen has also tripled this past week instead of decreased, so my transfer is likely being cancelled. Can you explain how this may happen, please?
So I can't explain why I would respond differently in one versus the other if you took the same dose. I can't address the period issue. You should get a period if you only took it on day 21 of the previous cycle. That won't stop you from getting a period on Lupron. As for your estrogen, if they gave it to you at the wrong time, Lupron's initial impact is to flare your FSH and LH, which means it gets them to increase before it gets them to decrease. So if you get it at the wrong time, it can actually make your estrogen levels go higher because you're actually stimulating egg production and egg growth. And in fact, we use that property of Lupron for what's called the microdose flare protocol, which we actually favor for our patients with weaker ovaries. So there are reasons for why it would happen, but it's a matter of when and who and what else was going on with your body. But that would explain it. And you don't necessarily need to cancel your cycle. If they withdraw your estrogen or block it, it should help things.
I had 7 embryos retrieved and no success with the first 3. 1 didn't survive defrost process.
Okay.
My ERA says I am 12-hour pre-receptive.
Yeah.
I'm debating, should I move to a new doctor who has a higher success rate versus sticking to the current doctor who is known not to change his protocol? Current doc says he would just had me take the progesterone oil 12 hours earlier based on ERA test for the next transfer. Question is, should I try with the remaining embryos with the current doc or try a new doctor and go through another retrieval?
So I don't know anything about your doctor because I don't know who you're referring to, obviously. So I'm going to talk in very general terms here. So step number 1, the ERA test is absolutely useless. So we've now had 3 shows on the ERA test because I hate the ERA test. So every single study out there has proven that there is no benefit to doing the ERA. It is scientifically incontrovertible that it doesn't work. Their own study done by the company that owns the ERA test showed no benefit. So it is completely useless to be pursuing an ERA, and do not follow that whole 12-hour thing. That's total nonsense. It does not correct anything for you. So that is not useful. Having said that, if you have failed 3 embryo transfers, I would want to know why. So there are tests you can do. There are always additional studies that can be done. There are things you can investigate. And if your specialist is not willing to look at other elements of what's necessary to evaluate, then yeah, of course I would leave them because that doesn't make sense. If I have a patient that has failed 2 embryo transfers, we hit the brakes and we start exploring what's wrong, because in our program, most of our patients don't fail within 2 transfers. Most of them are successful. So if I haven't succeeded for any reason by my second try, you know, first time you can chalk it up to bad luck, whatever. But if it's a second try and you still have not succeeded, we ask our patients to hit the brakes. Let's go back to basics. Let's check everything from A to Z, including additional tests, fertility testing for the hidden C, You can get that on www.fertilassist.com. We look at immunological factors. We look at infectious problems. We check the patient's progesterone levels very carefully, although we do that routinely anyways. So all of these things can be very, very important. You might need surgery to look for endometriosis. You may need an endometriosis protocol. Are they using all of the supplements that are necessary? Your melatonin, your HCG wash. Did you check your vitamin D levels? All of these things can be very critical and conducive to success. If they're not exploring those things, yes, you should find a different doctor, because your doctor probably cares more about money than they do about success. And I definitely advocate for patients to make sure that they are getting the very best protocol possible when they're doing their fertility cycles. That's why we do this show. People ask us all the time, why are you sharing your trade secrets? This makes no sense. You've got these great success rates. Why are you giving away your secrets to other people? I couldn't care less where you do your IVF. I just want you to be successful. So it's super important for people to get the best care. That's why we do this show. That's why we share our quote unquote secrets, because I want you to be successful no matter where you are.
Hello, Dr. V.
Hello.
Can you explain what a trigger shot is and when this is used and why?
Yeah. So a trigger, quote unquote, shot is an agent that is used to artificially make you ovulate your egg. So why do we use it? Well, in IVF, we have to, because if we don't know when you're going to release your eggs, and we want them timed so that we can retrieve them at the right time. So if you're doing IUI or IVF, it simply helps with timing of egg retrieval or insemination. And it also ensures, in the case of IUI, that the egg is actually releasing. So you want to make sure that that happens. There are different versions of ways to trigger people. The most common triggers are either HCG, which is actually the pregnancy hormone, or to use the GnRH agonist like Lupron in order to affect the release of your eggs. So if you're doing it with IVF and you have a very high egg production, then you want to minimize the exposure or eliminate the exposure to HCG, because that can cause ovarian hyperstimulation syndrome. So for example, if you're an egg donor, or if you are a patient who has a high number of eggs, like a PCOS patient, then you definitely want to get very minimal HCG, or you want to have just a straight GnRH agonist trigger. If you are an average person, then it actually is beneficial to double trigger. So that's the GnRH agonist and the HCG together. And there are studies, and again, we've reviewed that on the show, that demonstrate that the combination of HCG with the GnRH agonist is superior to the GnRH agonist alone. This actually carries over even into frozen embryo transfers. There was a study in Fertility and Sterility, I think last year or the year before, which demonstrated that a small amount of 1500 of HCG with the GnRH agonist improved your frozen embryo transfer success rates. So we do incorporate that into our protocol.
Can you tell us about progesterone hypersensitivity, please? Can someone with PROGS hypersense get pregnant naturally?
So it would probably be extraordinarily unlikely for you to be hypersensitive to progesterone, because you're born with it, you're raised with it, it's in your system. It would be very bizarre. There are some people that have hypersensitivity reactions to progesterone. It's like case reports only. So that's a problem, because it's literally part of your biology. So in terms of external progesterone, meaning you're taking progesterone, there are loads of women that react to progesterone in oil, not because of the progesterone, but actually because of the oil. So you can switch around the oils. Sometimes it's in sesame, sometimes it's in peanut, whatnot. So you can switch the oils till you find one that works for you. And then certainly the vaginal progesterones come in all sorts of different shapes, sizes, and compounds. So there's prometrium, there's crinone, there's endometrium, there's custom compounding. These are the more common ones. In Europe, I think they have one called Utrogest. So there's lots of different products that are available. But at the end of the day, the reality is that if you're sensitive to those, you just switch to another product.
Um, if husband used marijuana a couple of times a month before IVF cycle, should we postpone our cycle?
Yeah, you should. Marijuana is going to kill the quality of the sperm. So I would wait and clear things out for 3 months prior to doing your IVF. Yeah, and that's why we tell all our patients when they meet with us for the very first visit. I mean, I tell them from the first minute I talk to them. When they tell me they're using marijuana, I say, listen, I know it's going to come as a shock, but you must quit now in order to clear this from your system because it takes men 2.5 to 3 months to produce new sperm. So anything you do today, it's not going to show up for 2.5 to 3 months. So there's no question we tell them, and then we remind them again when we do their first visit with us. But if you are headed into an IVF cycle and your husband's been using weed, yeah, of course, postpone your cycle because that could make the difference between success and failure.
Similar question. How long should you be off weed before you try?
2.5 to 3 months.
Do you prefer fresh or frozen sperm for IVF?
We generally prefer to have fresh sperm. It's not mandatory. You can have frozen, but it's certainly better when it's fresh. So most of us prefer fresh sperm. There are some exceptions, but if there is a fresh sample available, it's often the better sample.
At 28, after a failed frozen embryo transfer, do you recommend 1 or 2 embryos for the next transfer?
Just one. I mean, piling on embryos does not help. And actually, back in the start of fertility factor fiction, we reviewed one study which looked at comparing single embryo transfer to double embryo transfer, and they actually showed that cumulatively you actually had a higher success rate with the singles than you did with the doubles. So we strongly advocate for one. The only times we put in two are if they were previously frozen as two and you don't want to like thaw, refreeze, rethaw, that kind of thing. Or if the patient's much older. So in an older patient, we'll consider it for social reasons and for success reasons. But in younger patients, it should only be one. And if you've had PGT testing, it should only be one.
Do you believe it's necessary to do a 4 to 6 month Lupron protocol prior to an egg retrieval for someone who has endo but also had 2 grade A embryos last retrieval without Lupron protocol?
No, so they've actually looked at that, guys. Lupron prior to IVF retrieval is not beneficial. Prior to transfer, it is, but prior to retrieval, it actually isn't. Now, interestingly, there was a study that we reviewed that showed that Vizan was helpful. And if you're in the US, apparently Vizan's not yet available. But if you are in Canada, Vizan is available, and we would recommend you use Vizan for 3 months.
So someone had a question asked, but I guess the advantage. So I want to ask their question now. I have a fibroid, and I've had it worked up and been told that it's not interfering with my fertility.
Okay.
Having said that, I'm doing IOI with you next month, and the fibroid is causing pain. What can I safely take for this pain? It gets pretty intense sometimes. Thanks.
So if your fibroid's big enough to be causing pain, we actually need to relook at whether or not it's affecting your fertility, because if it's causing pain, it's either degenerating, getting larger, or infected or inflamed or necrotic, none of which are good for fertility. So that needs to be relooked at first. Having said that, the answer to your question is simple. You can only use Tylenol or narcotics, and the narcotics we shy away from for multiple reasons. However, many of them are fertility related because actually narcotics can interfere with your ovulation and egg growth. So you can't use the non-steroidal anti-inflammatories like ibuprofen, naproxen, stuff like that, because that can inhibit ovulation. And you also shouldn't be on the narcotics. So really you're just looking at taking extra strength Tylenol. But you should have your fibroid reevaluated. So make sure you get a hold of our office. Tell them the fibroid's causing you pain. We'll reevaluate for sure. Great question.
In your opinion, how long should couples be fully off cannabis products before trying to conceive? Would the timeline vary for men or women? I've heard experts say anywhere from 1 to 3 months.
So for a woman, it's got to be at least a month because that's how long it takes to disappear from your system. And for guys, 3. And that's minimum. So a month for a woman minimum and 3 months for a guy minimum.
My husband had varicose surgery, and we are waiting for his next semen analysis.
Okay.
Do you think it would be beneficial to also get a DNA fragmentation test too?
Yeah. So as time goes on, I'm becoming more and more of a believer in DNA fragmentation assays. We do them on site now, and I believe that it does offer us valuable information. We have protocols in place to deal with sperm DNA fragmentation for IUI versus IVF cases. My embryologist is not a huge fan of using the Zymo device, which does reduce it for IUI for IVF because she feels that it impacts the morphology selection of the sperm. But for IUI, we do it, and we have seen some significant improvements. And for IVF, we do the second ejaculate 3 hours from the first and use that second sample, which very significantly reduces sperm DNA fragmentation. There's a recent study on that, and there's another one, I think, coming out, but it looks like it really does make a difference. And we tried it in-house, and it does. We saw a almost 30% decrease in sperm DNA fragmentation between the first sample and the second sample 3 hours later. So the guys just need to ejaculate twice, 3 hours apart.
You want to do some from your Instagram story?
From my Instagram, like mine? You
Yeah.
can't get them from yours?
I'll use all these.
Oh, okay. Yeah, sure. I guess so.
Or I can read them to you.
No, I got it. If I can figure out how to find the darn thing. There we go. Okay. Oh, wow. We got lots.
You have to do them fast.
Okay. You want the fast ones?
Yeah, that's how you do it. That's the only reason I want you to do it. That's your special
All
thing.
right.
Rapid fire Instagram questions.
Best tip for dealing with OHSS post-retrieval. Well, you shouldn't have OHSS post-retrieval because we should be using the right trigger for you. But if you do have a high-protein diet, lots of Gatorade, make sure you're mobile. There are medications you can take. We use Cetratide, we use Letrozole, Dostanex can help as well. And make sure you're following up with your doctor. You may need blood thinners, so probably aspirin. Does the form make a difference, edibles versus smoking? No. If you're getting THC or CBD, it's bad. Is CBD okay, or is all forms of marijuana unsafe? We don't know, but we suspect it's all forms, so stay off of all of it. Hi, Dr. V. 1 egg retrieved and fertilized. Should it be frozen on day 3 or day 5, age 40 plus? Wow, that is a great question. So it depends on whether or not you want to go all the way and do PGTA. If you're going to grow it out to day 5, then you probably should be doing it with the intention of doing PGTA. And if you're only capable of making 1 egg, meaning you tried hard but only 1 egg was the yield, then there is a higher chance that that embryo will be abnormal just by virtue of the fact that you're not producing as many, meaning the ovary is weaker, so the egg quality can kind of be weaker as well. So if you're going to do PGTA, I would say day 5. If you are not going to do PGTA, a very good argument can be made for doing it on day 3. However, I would argue against freezing it because there's no reason to freeze it on day 3. If you're just producing 1 egg, you should get a fresh transfer as long as they started your progesterone on time. So we normally grow out our day 5s because I want to make sure that they're making it to blast, but not for everybody. So there is a reasonable approach to it, being that you go for it and do a day 3 transfer. Fantastic question. Hi, Dr. V. When can I expect a withdrawal bleed? 10 days post Provera, 3 to 4 days. Do you think there is any safe dose of CBD when TTC? No, there is no safe dose of THC or CBD when TTC. And that's from our friend in Radiant Health Ottawa. We love you. You're a staunch supporter and great work you're doing out there, so thank you. Which antioxidants are good for sperm quality? All of them. Any of the vitamins, C, D, E, NAC, folic acid, coenzyme Q10, zinc is huge. pretty much any vitamin out there or supplement out there is good. Lycopene, resveratrol, the DHA, the fish oils are helpful. There's this great article I can pull up for you guys. Maybe we'll see if we can post it somehow. In any event, it's got all the vitamins that men are deficient in and how it improves things. So if I can find that for you, I'll see if I can send a link. What about CBD instead of THC? You know, I love the fact that people are just like clinging to the ability to want to use marijuana or its subproducts. Stop using it, guys. It is not safe. There is no part of it that's safe. Does the green help? Is almost over. Share. Oh, that's the thing that we were looking at. Yeah, that was it.
Okay, great. Good job. I think that should be a segment, by the way.
A segment? Rapid fire.
And I have to
rapid fire fertility.
Like 30 seconds. That'll be the challenge for next week.
That's crazy. Seconds. I can't do that. Do we still have other questions?
Yeah, obviously.
8:55. We'll give it another few minutes. I got to make a phone call to a patient after this. So.
Okay.
Mm-hmm.
Okay. I had COVID last year.
Okay.
And still experiencing residual long-term effects.
Oh, sorry. Long hauler.
I have nodules in my right lower lobe. I'm 40 years old. Should I wait until I'm feeling completely 100% before wanting to try and get pregnant?
Nodules in the right lower lobe of your lung? Probably not, unless it's compromising your respiratory function. But that's something where you would need the opinion of a respirologist, not a fertility specialist. So, I mean, if you're compromised, if your lung function is compromised, you should wait. Because that could be dangerous. But then in that circumstance, you might want to look at a surrogate. If you're 40, she said she's 40?
Yeah.
Yeah, I mean, waiting any longer can compromise your fertility. So I would see a respirologist right away, get them to do pulmonary function testing on you, and then decide what you're going to do. It may be reasonable to go ahead and make your embryos and then wait until you're healthy enough to carry them, or choose to use a surrogate if you unfortunately don't get healthy enough or are worried about it. But I would go ahead and make your embryos and then wait to do your transfer till you're in a good place.
Is it normal to have fever blisters few hours after embryo transfer?
No, it's 100% not normal to have fever blisters a few hours after your embryo transfer. You're either allergic to something that you were given or something funky is going on with your system. And that's definitely not a good thing because we don't want your immune system that active. So that's a situation where you want to be on steroids or something to tamp that down.
I'm taking some topical estrase creams for other issues, and I was wondering if that would affect my estradiol levels and IVF cycles. Thanks, much appreciated.
Yes, for sure it will. Topical estradiol is one of the ways that we get estrogen into women. Estrogel is a product that we use routinely for hormone replacement therapy. Estrogen patches when we're doing FETs. So if you're putting some kind of cream in, it's going to alter your estrogen level, and that can actually inhibit your egg development.
Wow. I didn't know that. I couldn't imagine.
Tarek said he didn't know that, guys. I don't know if you heard him off camera. You know we've been doing this a long time when Tarek starts feeling comfortable dealing with the medicine.
I'm telling you, I can do this. Is ICSI necessary if sperm count and motility are excellent?
Okay, so every study out there right now says that if you do not have severe male factor, ICSI is actually not beneficial. However, most of those studies are done at centers where their ICSI success rate is what I would call suboptimal. And so they're not really valid because if you look at our center, we're getting an excess of 90% fertilization success. Every morning, my embryologist comes and shows me our success rate with a great big smile on her face because she's insanely good. And so she's getting like 100% day after day after day after day after day. I give her a mature follicle, she gives me a fertilized egg, even when there's just one. So she is doing incredibly well, and the vast majority of our eggs will fertilize. So in that circumstance, we don't have data because most of the studies are using like a 70% ICSI success rate. We're getting over 90. So it's hard to know what the right answer is there, but it's not necessary. And there are side effects to using ICSI, but we use it for all of our patients because it improves the fertilization rate so much when we do that.
I'm 43, 2MC, 1 chemical, other trisomy 21, 1 to 5 year natural kid. IVF protocol, birth control, Gonal F 300 units, Menopur 150, Letrozole 2.5, Ganarex 250, Overdrol 250,
Okay. Don't worry about it.
Axamocercin. Thoughts?
Well, I wouldn't put you on birth control because that doesn't make sense. Birth control in someone over 40, we don't even use it over 38, will suppress you. So that doesn't make a lot of sense to me. The rest of it all sounds fine. I don't have any problems with the rest of that. We do balance our recombinant to urinary gonadotropin. So instead of 300, 150, we would use 225, 225. Supposedly it decreases the chances that your embryo will be genetically abnormal. However, you need a lot of eggs at 43 to achieve success, unfortunately. So whatever you're doing, if it's not yielding a lot, then you either have to keep trying, which is fine, or you need to reconsider what you're doing or how you're doing it, or roll the dice, and that's perfectly fine. But your physician needs to have that discussion with you. We spent a lot of time developing our embryo math video on our YouTube channel, which is easy to find because under popular uploads, it's now number 2 with over 20,000 views. So go there because the last segment of it is for women that are 43. We actually did the math for someone that's over 43. You need a lot of cycles to achieve one success when you're over 43. So you have to watch that and just get a good appreciation of what's involved mentally, emotionally, physically, medically, and of course, financially as well. So it's important.
What are the chances of moving forward and completing the cycle with lead follicle being 11.5 day 15?
Day 15?
Yeah, 11.5, day 15.
For IVF, I wouldn't do it. For IUI, it's fine. But if it's IVF and you've been stimmed for 15 days, we would have canceled you 3 days ago. So I would not continue. That egg quality will not be good.
Are there any instances where the embryologist can disclose the gender of embryos to patients? For example, my husband has family history of testicular cancer.
In Canada, only if there is a sex-linked genetic condition like Duchenne muscular dystrophy. So if there is a sex-linked condition, we can say we don't want that particular sex because it's a risk. But aside from that, no, under no circumstances in Canada can you sex select. You can do it in other countries, but as a Canadian, it's actually illegal to even acquire sex-selected embryos outside of Canada. And I went through all of the legal mumbo-jumbo on this with the amazing and incomparable Michelle Flowerday from Flowerday Law, who made it really clear that as a Canadian, if you're seeking this service outside of Canada, you're still actually breaking the law. So you cannot sex select under any circumstances.
A comment. Hi, Dr. Victory. No question, but just want to thank you for the great egg retrieval transabdominally.
Oh.
We got 14 eggs versus 5 at another clinic, 10 mature fertilized, and all 10 made it to day 5.
Hi, DR. I know who you are. So thank you for watching. You were awesome. Thanks for tolerating it very well. Yeah, thank you for the comment. I am very, very excited for you. So thank you for the thanks, but thanks for letting us be part of your care. You guys are an awesome couple. I love you both.
I've had 7 early losses. I did an egg retrieval and I have 3 PGS embryos frozen.
Okay.
I am terrified to transfer because I don't believe it's going to work.
Right.
My protocol will be Lovenox and prednisone. Yeah.
What do I think?
Do you have any advice?
Yeah, don't do anything until you've had someone go over every single aspect of your health and well-being before you do your embryo transfer. So if you got 3 PGS normal embryos from your IVF cycle, the likelihood you had all abnormal embryos miscarry before is low, which means that there must be something else wrong. So whether it's immune mediated, infectious mediated, problem with the shape of your uterus, sperm DNA fragmentation, whatever the case is, you need thorough evaluation before you do your embryo transfer. So those are cases where we look for infection in the uterus with hidden C. We do the immune testing to see if there's a problem. We would run a thrombophilia screen. Some people say it's not important, but I disagree respectfully. We would recheck your thyroid. We would check your thyroid antibodies. We would explore the sperm DNA fragmentation. We would make sure you're not smoking, drinking, using any kind of drug. So make sure your weight is appropriate, your vitamin levels are up, your vitamin D is excellent. So there are all sorts of things that need to be done. And you need someone who is A, an expert in that, and B, really cares about you, who actually won't let you do an embryo transfer until they've addressed all of those things, because it's important. Simply taking Lovenox and steroids without knowing what's wrong is actually nonsensical. I'm all for it if I've exhausted everything, or I feel that the benefit outweighs the risk from a cost perspective. So keep in mind, steroids can be useful in certain circumstances, especially if there's an immune-mediated problem. And immune testing is like $2,500. So it's not practical for everybody to do that. You can buy prednisone really cheap versus doing the testing. So in some circumstances, we do advocate for not testing. But the other tests I would say you need to do so that we can figure it out as long as the costs are reasonable. And so that's something that is really important. So make sure your physician is testing every single thing about you before they jump into a cycle.
A lot of people saying, welcome back, Tarek. Just thought I'd let you know.
Welcome back, Tarek. And everybody, big round of applause for Tarek. Lots of thumbs up and the little hearts and all that stuff. We love Tarek. It's good to have him back.
Can you drink alcohol during egg retrieval cycle? And can you drink alcohol prior to your egg retrieval? Does alcohol have any effects on the process?
Yes, it's terrible for your eggs. It's wretched for the sperm, and it even has effects on your endometrium and your placentation and all that stuff. No booze, no smoking, no drug use, zero, none of that stuff. Alcohol, just to put it into perspective for you guys, is a class 1 carcinogen. Okay, so we know for a fact that it causes 7 different types of cancer and 4 more that they believe it likely also is responsible for, including breast cancer, by the way. So alcohol is terrible for you. And if you didn't believe that part, or you still have doubts, okay, right now in the midst of this global pandemic, what was the first thing that flew off the shelves that everybody is encouraging the use of? Hand sanitizer. Why? Because the hand sanitizer kills viruses, kills bacteria. Why is nobody getting sick with the common cold and the flu and all of this stuff? Because 1, we're wearing masks, and 2, we're constantly washing our hands and hand sanitizing. What is hand sanitizer made of? It's made out of the exact same alcohol you're putting into your system when you're drinking alcohol. So you're actually consuming the rough equivalent of hand sanitizer. It's designed to kill stuff. Putting it in you is just killing stuff inside you. So there is no part of alcohol that's okay at all. In general, it's not good for you, but in fertility, it's a disaster. Do not drink before any part of your fertility.
9:08 starts up.
9:08? 2 more minutes?
Sure.
You got enough energy?
You got a lot of questions, man. I'm here for you. Okay.
We could keep going all night, I guess.
I'm sure.
The 2-hour fertility factor fiction show.
Marathon. 35-year-old female.
Okay, 35.
FSH 9. AMH 6. With lighter periods and shorter time in between cycles. 2 endometriomas in the ovaries.
Ooh.
Best to go straight to IVF or worth it to try with letrozole first in IUI?
So if you have AMH of 6 nanograms per mil, you've got very strong ovaries. I would probably say it's okay to try letrozole. If you've got an AMH of 6 picomoles per liter, you've got weaker ovaries, and I don't like jumping into things. I would want to see everything, but I would probably recommend that you go right to IVF, especially with bad endo like that with 2 endometriomas.
Amazing. Yes, thank you, doctor. I don't know what it's referring to now, but they liked it. Smiley faces, laughing. Anytime. I don't know. Thank you, much appreciated. Okay. Can any test be done on first sperm for a male who finished cancer treatments 1 year ago, 25 radiation sessions, to see if it would be better to use IVF than to use the frozen before radiation?
I think they meant to use fresh versus frozen. Yeah, you could do a sperm DNA frag, the semen analysis. Fertility offers this oxidant level test as well. So they measure the amount of oxidation in there. So there are some tests you could do that would be worthwhile. Yeah, I would recommend you consider that. All of those are useful. You can get them at Fertility, or you can get them at a basic lab if it's just your semen analysis. So check out those services. Is it going to distinguish which sample you should use? No, but will it at least guide you to the fact that the current sperm samples are reasonable? Yeah, it'll give you an assessment of whether or not they're reasonable.
Hey, Dr. V, what are the chances of completing my cycle being on a 15-day with a lead follicle being 1.5?
That was the one that asked it.
Yeah.
Yeah.
Can any test? I'm 37 with low AMH. I got 4 eggs retrieved from 3 frozen blasts left.
Oh, wow.
4 AA, 4 AB, 4 BC. Should we transfer 1 or 2?
Always transfer 1. So a single embryo transfer is safer, it's healthier, less complications, and it allows us time to adjust. God forbid it doesn't work. We got to adjust things for you. Maybe you need more testing, maybe you need different treatment, whatever. Sometimes we learn as we go, so you want to save more chances.
Hi, Dr. V. Thank you for the smooth procedure yesterday.
Oh, you're welcome.
Sorry for causing commotion in the OR prior to IVs make me squeamish. You're the best.
You're very welcome, and you were a piece of cake. So, and you took the IV like a champ. So well done, bravo.
Yeah.
We're good.
Yeah.
Okay, guys. Thank you for joining us as always. Very happy to have had the chance to share our knowledge on marijuana with you tonight. Make sure you like, comment, and subscribe. And I would love to challenge all of you that are watching to go out and find more followers for the impossible to follow Instagram. But watch our YouTube, get your friends and your family and your other followers to follow us on YouTube. The channel is awesome. Everything we do here at FFOF is on the YouTube channel. So we'll look forward to seeing you next week. Are we doing Monday next week? It's the Easter Monday. I'm ready. Are you ready?
Yeah, I'm not doing anything.
Yeah. All right. So the 2 of us will be back next Monday, and we hope to see you there. Have a great night.